Let's carry on with our rash revision. So COPD management. COPD in over 60-year-olds, non-pharmacological management and use of inhaled therapies. Confirmed diagnosis of COPD. The fundamentals of COPD care: offer treatment and support to stop smoking, offer pneumococcal and influenza vaccinations. Usually the pneumococcal vaccine is a one-off vaccine, the influenza vaccine is an annual flu vaccine every year. Offer pulmonary rehabilitation if indicated. Co-develop a personalized self-management plan. So there's an asthma action plan. You can also have a COPD self-management plan, an action plan. Optimize treatments for comorbidities. For instance, if the patient has hypertension, the person has developed heart failure, called pulmonary, the person is diabetic, of course, he needs to optimize treatment for comorbidities, sleep apnea as well, things like that. Or obesity, the weight management. You need to think about all those other parts of the management of the patients. These treatments and plans should be visited at every review. Start inhaled therapies only if all the above interventions have been offered. If appropriate and inhaled therapies are needed to relieve breathlessness and exercise limitation. And people have been trained to use inhalers and can demonstrate satisfactory techniques. So it's really important to ensure proper inhaler use. Proper inhaler use is so important. Proper inhaler use is paramount. When you are initiating a patient on inhalers. Review medication and assess inhaler technique and add evidence regularly for all inhaled therapies. So in terms of treatment, you have to offer a short-acting beta agonist or a short-acting muscarinic antagonist to be used as needed, PRM. If the person is limited by symptoms or has exacerbations despite treatment with these. If there are no asthmatic features or features such as steroid responsiveness, then offer LABA. So long-acting beta agonist like salmeterol or LAMA, like tiotropium. If the person has day-to-day symptoms that adversely impact quality of life, then you consider the trial of this triple combination, LABA plus LAMA plus inhaled corticosteroid, such as Trimbo. If no improvement, revert to LABA plus LAMA, so we take off the steroid. So if you look at this is unlike asthma. In asthma treatments, when you look at asthma treatment, you find that usually in asthma treatment, the first medication, that is apart from the SABA, first medication is usually introduced as a preventer. My stabilizing medication is the inhaled corticosteroid. You can see that in the COPD management is not inhaled corticosteroid, it's added. First of all, you add a LABA, plus LABA. If there's no asthmatic feature, if there are features of asthma, such as asthma, COPD overlaps with the asthmatic features, or if you have features such as steroid responsiveness, for instance, if you have been raised eosinophil levels, you're having some reversibility, and maybe some diurnal variation in symptoms, things like that, some asthmatic features, eczema, and all that. So the patient was asthmatic and has developed COPD, so you'll be thinking, okay, fine, and LABA plus inhaled corticosteroids. So the steroid parts usually help with the asthma. The LABA plus inhaled corticosteroid. The person has day-to-day symptoms that adversely impact quality of life, has one severe or two moderate exacerbations within a year. Offer LABA plus LAMA plus inhaled corticosteroid. Explore further treatment options if still limited by breathlessness or subject to frequent exacerbations. See guidelines for more details. So if the person is having one severe or two moderate exacerbations within a year, you need to be thinking of optimizing their treatment. Asthmatic features or features suggesting steroid responsiveness in this context include any previous secure diagnosis of asthma or atopy, a higher blood eosinophil count, substantial variation in FEV1 over time of at least 400 mils, or substantial diurnal variation in peak expiratory flow, so at least 20% diurnal variation. We usually suggest there is some asthmatic feature as well. Be aware of an increased risk of side effects, including pneumonia in people who take inhaled corticosteroids. So something needs to inform the patient that if the patient is on inhaled corticosteroids, an increased risk of pneumonia, obviously, because steroids can lower the immune system, immunity. Documenting clinical records the reason for continuing inhaled corticosteroid treatment. In COPD, usually you can see that LABA-LAMA is usually preferred. LABA-LAMA, inhaled corticosteroid needs to be added if there is a reason, clearly documented reason for adding a LAMA-LABA. Because you can see here, if there are no clear asthmatic features of steroid responsiveness, but patient symptoms are still not controlled on LABA plus LAMA plus your SABA or SAMA, and then you add the inhaled corticosteroids, the patient's symptoms are still not improving. You have to take up the steroids. Management of adrenal crisis, Addisonian crisis. I think we looked at the adrenal sickle. We came across the fact that the patient is unwell. You might need to double their hydrocortisone or prednisone dose. Of course, inform their doctor. Well, now this patient is in adrenal crisis already. So we need to be giving 100 milligram hydrocortisone IV or IM, followed by continuous infusion of hydrocortisone. And of course, fluid resuscitation, because they usually have they have a distributive kind of shock as well. They have a hypovolemic kind of shock, hypovolemic shock. So you need fluid rehydration. So refer to endocrinology for further advice on diagnosis, starting regular oral steroids or tapering steroids. Education regarding sick day rules prior to discharge. So adrenal sick day rules, very important. We saw that earlier. Just to have an idea of the things, parameters that actually make up the Q is 3. Just know that the age, sex, ethnicity, smoking status is part of it, diabetic status. The patient has had an angina, heart attack in the first degree, less than 60 years of age. The patient has chronic kidney disease, stages 3, 4, 5. The patient has atrial fibrillation, the patient has blood pressure treatments. They have migraines, rheumatoid arthritis, SLE, severe mental illness on atypical antipsychotic medications. If they are regular steroid tablets, they have a diagnosis of erectile dysfunction. So it's just good to know when you're doing your cardiovascular risk assessment, you need to be knowing the things that actually can affect the patient's cardiovascular risk. So CKD, smoking, obesity obviously is there because BMI, so cholesterol level, obesity, of being overweight or obese, obviously will also increase that. So you need to be knowing these things when you're doing your cardiovascular risk assessments. We looked at HRT, we looked at the breast cancer side of HRT. We've done that at the beginning. There's something here. HRT prescribing a migraine. So let's read this. What pharmacological options are there which have evidence of efficacy for management of vasomotor symptoms and prophylaxis of migraine? So hormonal, post-hysterectomy, continuous transdermal estrogen. If the uterus is intact and the patient is premenopause, then continuous transdermal estrogen plus levonorgestrel IUS, which is Mirena coil. The uterus is intact and the patient is postmenopausal, continuous transdermal estrogen plus levonorgestrel IUS, or continuous combined estrogen progesterone patches, or continuous transdermal patch plus micronized progesterone to progesterone, or tibolone. So tibolone alone can be used as a HRT. Lowest estrogen dose required to control there's some other symptoms. You need to start maybe if you is it estrogen tablet usually starting at 1 milligram. If it's the Evoral, usually starting at Evoral 50, if it's the pump, usually starting at 2 pumps per day. Then you can always titrate upwards if the symptoms are not yet fully controlled. So non-hormonal, so SSRIs can be used, obviously, escitalopram and SNRI, the duloxetine, venlafaxine can be used. Um, so, yep. So migraine is not a contraindication for use of HRT. If one has a migraine, they can still have HRT. And we've looked at migraine, we've looked at HRT. Hypothyroidism treatment algorithms is important. We'll just have a review of these. Um, hypothyroidism. I think my ST3, so my primary care, I've had only one patient with hypothyroidism. So adults with hypothyroidism consider antithyroid medications with supportive treatments while waiting specialist treatments, assessments, offer antithyroid medications in specialist care. So people waiting for radioactive iodine therapy. Blah, 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 blah. Skip those minutes importance. So management of primary hypothyroidism in young patients below the age of 60 without ischemic heart disease, start levothyroxine at a daily dose of 1.6 microgram per kilogram body weight, equates to 100 microgram daily for the average size woman, 60 kg, and 125 microgram daily for the average size mass of 5 kg. 85% of patients are euthyroid on 100 to 150 microgram. Levothyroxine should be replaced cautiously in older patients over 60 years and those with ischemic heart disease. The starting dose of levothyroxine in these instances should be 25 microgram daily. You start at 1.6, so the person is like, it's like 1.5, the person is 70 kilogram. Thinking of 125, yeah, about that. But the person is more than 60 years, or has ischemic heart disease, then we should be starting much lower, like 25 microgram daily, and then we can always titrate upwards. The long half-life of levothyroxine means that if a dose is missed, it can be taken the next day. It has long half-life. There's no sufficient evidence at present to support the routine use of T3, which is harder to monitor. It's more likely T4, TSH actually, that we usually use. Monitoring the effect of treatment, repeat thyroid function tests, usually TSH, every 4 to 6 weeks after the initiation of treatment. Once stable, yearly measurements are advisable to check compliance and if dose is still appropriate. The aim of therapy is to have the TSH in normal range. Most patients feel symptomatically better with a low normal TSH. Means, low normal TSH is, she's suppressed TSH. And high normal free T4. Symptomatic improvement begins in 3 to 4 weeks, but may not be complete for several months, especially when myopathic symptoms are present. Lifelong levothyroxine is required. Yeah, usually once a patient has hypothyroid, you start them on levothyroxine. Most of the time, it's going to be lifelong, especially in primary hypothyroidism. Now, how do you manage hypothyroidism in pregnancy? Hypothyroidism in pregnancy associated with maternal and fetal complications and should be treated. In patients with pre-existing hypothyroidism, most patients require an increased dose of levothyroxine to keep the TSH ideally less than 2.5 milliunits per liter. This increase often occurs early in the first trimester. Patients with known hypothyroidism should increase the dose of levothyroxine by 50 microgram daily as soon as pregnancy is confirmed. So if the patient was 100 and increased to 150 or 125, increased to 175, they should have their thyroid function tested early in the first trimester. and then 6 to 8 weekly throughout the pregnancy. So every 6 to, you can say every 2 months, have a thyroid function throughout pregnancy. I was thinking that range is 25 to 50, to 50. And management of subclinical hypothyroidism. Subclinical hypothyroidism. About 5% per annum progress to develop overt clinical hypothyroidism. And the predictors of progression are high titer TPO, thyroid peroxidase antibodies, and age over 65. So if you have high TPO, it tells you that it's more likely an autoimmune hypothyroidism, the Hashimoto um, thyroiditis, something like that. Yeah, so they're more likely to have a destructive thyroid disease going on that will push them into clinical hypothyroidism. Therapy, TSH greater than 10, prevent progression. So if TSH is greater than 10, you're saying TSH is not well suppressed. So prevent progression by initiating levothyroxine therapy. If TSH is less than 10, with presence of thyroid peroxidase antibodies, repeat thyroid function annually. If TSH is less than 10 and there are no TPO antibodies, repeat thyroid function every 3 years. If TSH is greater than 4.5, because consider treatment if symptoms or high titers of thyroid peroxidase. So it's just about um, if there are thyroid peroxidase antibodies or not, and then for it versus the level of the TSH can help you decide. Subclinical means the patient is not having symptoms. Or rather, no, is that what subclinical means? Subclinical, yeah, obviously the patient is not having symptoms. But the TSH level is within the hypothyroid level, unsuppressed TSH. Contraception and UK MEG is quite important to know. What are the common contraceptives? Ones that actually have issues with contraindication of the combined hormonal contraception. That's one we usually need to be aware of. So if a woman has just given birth, so from 0 to the first 6 weeks postpartum, complete absolute contraindication for combined hormonal contraception within the first few 6 weeks. That's at the higher VTE risk kind of stage. Now, between 6 weeks and 6 months, less than 6 months, equals to 2, which means you can still safe. Beyond 6 months, obviously, there's no VTE risk. So for the first 6 months, should not complete contraindications to using this combined hormonal contraception. Now, for postpartum in non-breastfeeding women, so under less than 3 weeks with other risk factors for VTE 4, without other risk factors for VTE is 3. Due to less than 6 weeks with other risk factors VTE 3, without other risk factors. So in non-breastfeeding women. Okay, so I think the reason why you shouldn't use it here is because it can affect breastfeeding and of course the VTE risk as well. Postpartum sepsis, you can see anything, you don't put any foreign body into the uterus, both murine and copper. Postpartum sepsis, absolute contraindication for, you don't put them. So the copper IUD and the monogesture can be inserted less than 48 hours postpartum, within the first 48 hours postpartum. Beyond 48 hours, so less than 4 weeks, you shouldn't. It's not that advice you cannot 3 because of the risk of uterine perforation at that stage. If you're going to insert an IUD, copper IUD, postpartum insert it within the first 48 hours. Most abortion steps the same thing. You don't put any foreign body and mirror or copper, you can see that. When it comes to smoking, because in the SCA, patient might be asking for contraception and you might find out that she's smoking and you have to check her age, how old is she? She's less than 35 years. Irrespective of how much she's smoking, you can still prescribe unless she's under 35 years. If she's 35 years or more, then she's smoking less than 15. Still advise that you shouldn't UK-MEC3. If she's smoking 15 or more, she's up to 35 years, then it's an absolute contraindication. So you be strongly, completely advising against combined pills. So you need to be able to work that out. If she stopped smoking over less than a year ago, you still have to say, she's 35, she stopped smoking. So recently smoked. It's more than a year or more ago, she stopped smoking. You can throw it down to UK-MEC2. And when it comes to obesity, if her BMI is 35 or more, if she's morbidly obese, if she's morbidly obese 35 or more, then you don't want to be using the combined hormonal contraception. But then obviously her risk of breast cancer, and even VTE will be increased. It's very important to note this age, smoking and how it relates to age. Because it's coming in the exam, maybe you're discussing with the patient who is 34 or a patient who is 40, or is currently smoking maybe 10 a day. So the patient is 40, smoking 10 a day is less than 15. So you still well advised against a combined pill. Uncontrolled hypertension, you wouldn't want to give the combined hormonal same thing, vascular peripheral vascular disease. You don't want to give combined hormonal contraception because of increased risk of VT. There's a history of VT, then you probably wouldn't want to be giving that. There are safer options at that stage. If the patient currently has a VT on anticoagulation, even if the patient is on anticoagulation, you can see that it's complete contraindication, absolute contraindication to use a combined hormonal contraception, even if the patient is on VT, you can see that. Major surgery, prolonged immobilization. You don't want to use combined hormonal because of increased risk of VTA. The person has known thrombogenic mutations, factor 5 leading importance, protein mutation, protein S, protein deficiency, antitrophin deficiency, prothrombogenic. So you don't want to use COC because of the increased risk of developing VTA. So varicose veins, person has varicose veins, nothing. Even they have superficial venous thrombosis, you can still prescribe COC. Or if you have DVT or PE, fast or current, you don't prescribe COC. The patient has atrial fibrillation. The patient with atrial fibrillation, you can see you don't want to, of course, the problem with atrial fibrillation is there's increased risk of cardiac thrombosis, embolization, and stroke and all that. That's why we usually typically place patients on anticoagulation AF. So they are both thrombogenic, and that's in that sense. So you don't want to, it's an absolute contraindication. So you don't use combined hormonal contraception in atrial fibrillation. Migraine. So migraine, and that scenario that can come out in the exam is a patient who has migraine, patient wants contraception, is finding out if they do suffer with headache or migraines, and they experience aura, and they experience aura, flashing lights, and bad tastes, bad smell, any particular symptoms that warn them when they're about having their migraines, which is aura. So there's aura, and it's a contraindication for because at that stage combined pulmonary congestion will be both homogenic, including the risk of ischemic stroke, altogether. The person has spine pain but without aura. eh, you can initiate combined hormonal contraction, but if the person is already on it, you might need to be discussing changing it. So discontinue. So three, thinking about changing it and prescribing a safer option like a pop or an implant or an renal coil or something, or from the DMPA, the polymeroxy progesterone oxidase, the injection. The person has unexplained vaginal bleeding, you don't want to put anything in. You don't want to put anything in. But if they already have a renal coil in, then you might need to, it may be safe to leave it in, especially if they're young. Persistently elevated HCG levels or malignant disease for renal and copper coil. Because you might even be thinking if they have a gestational trophoblastic disease or something, choriocarcinoma, or even pregnancy. So breast cancer, if the patient has a current breast cancer, you can see that for all forms of hormonal contraception from the marijuana. So if the patient has current breast cancer, it's only the copper coil is actually safe. All other forms of hormonal contraception, COC, POP, depot, and everything is absolutely contraindication. So past breast cancer, still advised not to give. So UKMF3, still advised not to give. The thing that is safe in either current or past breast cancer is the copper coil. So it's actually worth knowing that. Of course, PID, you don't want to initiate, but they already have if the patient has current PID, if the patient has a Mirena coil or a copper coil, it's not an absolute indication for removal. You can see that. So, but if they already have the infection, you don't want to use an absolute contraindication for initiation for insertion. But if they already have it in there, then you can take some swabs or start them on broad spectrum antibiotics. And obviously the infection is not improving, then obviously you're not considering moving it, moving your coil. So cirrhosis, the patient has severe decompensated liver cirrhosis. So complete contraindication to COC. And then, absolute contraindication, preferably not to still prescribe other forms of hormonal contraception in severe decompensated liver cirrhosis. Unlikely that one is unlikely to come out in the exam. It's more likely going to be young patients who wants contraception, and maybe she smokes, and maybe have a family history of DVT, has had breast cancer in the past. If there's breast cancer in the past, you should be thinking, oh yeah, copper coil, actually. Positive antiphospholipid antibodies obviously combine hormonal conversions completely contraindicated for increased risk of VTE. Yeah. So the patient has SLE. It's not having SLE is not an absolute contraindication to combine pills, except because if the person has SLE, you have to know if they have antiphospholipid antibodies or not. If it's negative, you can prescribe combined. If it's positive, if you cannot because it's it contributes an essential death risk of VTE. That's heart failure diagnosis. Typically, once you suspect heart failure, so chronic heart failure suspected, take a detailed history and perform a clinical examination, checking for, of course, crackles or crepitations in the chest, and checking for pedal history, looking for shortness of breath on exertion, leg swelling, things like that. Fourth is pushing, for instance, cough, autopnea, PND. Person might have a history of hypertension, might have had a myocardial infarction in the past, things like that. Person might have COPD, things that can cause pulmonary. So measure the NT-proBNP, perform ECG, consider a chest X-ray, blood tests, urinalysis, peak flow or spirometry. Now, depending on the BNP level is less than 400, heart failure not confirmed, consider other causes of symptoms with specialist inputs if concerns persist. If your BNP is between 400 and 2000, refer urgently to be seen within 6 weeks. Or happen there that is a specialist clinical assessment, including transthoracic echo. Now, the echo will either confirm heart failure or rule it out. If heart failure is confirmed, assess severity, establish etiology, and identify correctable factors. If your BNP is greater than 2000 nanogram per liter, refer urgently to be seen within 2 weeks. And as the direct access echo is not, the echo will be performed. So it just depends. The level of your BNP depends on the patient you've seen within 2 weeks or 6 weeks, or if all of them will have an echo anyway. There's a couple of things that can cause a falsely raised or falsely low NT-proBNP. So factors can cause elevation of the BNP level. So of course, left ventricular dysfunction, previous heart failure, advancing age, renal dysfunction like COPD, acute coronary syndrome, pulmonary disease, COPD, right? So pulmonary embolism, high output state, sepsis, cirrhosis, hyperthyroidism, atrial fibrillation. Now, things that can cause a low level of BNP, obesity, this BNP, yeah, natural erotic peptide, brain natural erotic peptide. So cardiac component, pericardial constriction, heart failure etiology upstream from left ventricle. Not really important, not really. I don't think that's really important for now. How do you manage heart failure essentially? Heart failure management, chronic heart failure diagnosed by specialists, offer diuretics for congestive symptoms and fluid retention, but typically look diuretics for someone. Heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction. So there's preserved ejection fraction. Typically, it's about managing the fluid overload. Manage comorbidities such as hypertension and AF, ischemic heart disease, and diabetes in line with the NICE guideline. Offer a personalized exercise-based cardiac rehabilitation program unless condition is unstable. Like if the heart failure were to reduce ejection fraction, you offer the ACE inhibitor or ARB and a beta blocker like bisoprolol, atenolol. You can prescribe a mineralocorticoid receptor antagonist like spironolactone if symptoms continue. Consider an ARB if intolerant of ACE inhibitor. Consider hydralazine and nitrates. So SSOM mononitrates and hydralazine if intolerant of ACE inhibitor and ARB. So ACE inhibitor, beta blocker, spironolactone if symptoms continue. If symptoms persist despite first-line treatment, seek specialist advice and consider one of the following. You can replace the ACE inhibitor or ARB with sacubitril valsartan if ejection fraction is less than 25%. Sacubitril, I think, is a BMP antagonist. It's a brain natriuretic peptide antagonist. I think that's sacubitril, yeah. Add ivabradine. You can add ivabradine for sinus rhythm with heart rates more than 75 and ejection fraction is less than 5%. So ivabradine is an option. Add hydralazine and nitrate, especially if of African Caribbean descent. Digoxin for heart failure with sinus rhythm to improve symptoms. So cardiac resynchronization therapy, implantable cardioverter defibrillator, measure serum sodium, potassium, and access renal function before and after starting each, each dose increment. That's for circulatory valsartan, ARBs, ACE inhibitor ARBs, to measure your renal function before starting and with every dose change. If EGFR is 30 to 45, consider lower doses or slower titration of ACE inhibitor ARBs, spironolactone, circulatory valsartan, like the digoxin. So that's very careful. When the digoxin is a dangerous drug. For circulatory valsartan, it's an ARB combined with sacubitril, which is a BMP antagonist. Sacubitril, a BMP antagonist or agonist. Let me just double check. Just flashed through my mind that might be sacubitril. So sacubitril inhibits the enzyme neprilysin, which is responsible for degradation of. So it's not an antagonist. So it's more like it's similar to it increases the amount of BMP and AMP, both atrial and brain natriuretic peptides. So it's a neprilysin inhibitor. So neprilysin is the enzyme that breaks down BMP, because obviously in heart failure, the body produces BMP as a compensation to help buffer the effects of the heart, of the failing heart. So BMP is actually positive, a useful hormone. So what you want to preserve BMP as much as possible. So you use a neprilysin inhibitor, which is sacubitril. Yeah. Don't forget cardiac resynchronization. Don't forget cardiac rehabilitation. Cardiac rehabilitation and things like that, especially through assessment. So those are things that very important to be mentioned. We'll still look at emergency contraception because it's important.